Welcome to Plugged Inland. I'm Roger Bowman. In this episode, we discuss the state of healthcare in the Inland Empire and the challenge to the system we can expect from our renewed population growth. As an example of a facility expanding to meet this need, let's take a look at San Gorgonio Memorial Hospital. Joining me in studio is Mark Turner, the CEO of San Gorgonio. Thank you very much, Mark. Memorial Hospital. Thank you for being here. Thank you for correcting my bad diction.
You're welcome. Thank you.
What is San Gorgonio?
What is San Gorgonio? Well, we are a community hospital. Started in 1951. We are actually a district hospital, which makes us a special governmental unit of the state of California. And our mission is to provide community health care to everyone that lives in the San Gorgonio Pass area.
So we saw the clips of the hospital. That does not look like a Mayberry hospital.
No, it doesn't. This is a hospital that's in transformation. It started out as a small rural hospital and represented small communities for much of its lifespan. But in recent years, with the incredible growth that we've seen in the Pass area, we've embarked on a construction master plan to be able to not just replace our facilities, but expand those as well to match the expanding population growth that we've had in the Pass.
Do you consider yourself a very modern facility now?
We're becoming that way with our facilities, that is, because we're just about done with our first phase of a three-phase master plan project. So the first phase is going to allow us to complete our infrastructure improvements as well as open up our new emergency department and ICU building.
I wanted to mention the acronym ED,
Yes.
just to make sure everybody understands. That is
Emergency department, better known as the ER to
go.
most of us, yes.
Okay, so you have an ER and an ICU.
Correct.
And are they open now?
You know, the building is completed. We have not been able to put it into use just yet because we're stocking the building with supplies, training our staff on the use of the systems. and awaiting survey. Once we're surveyed by the state and we pass that survey, we're ready to see patients. Hopefully that'll be in the next few weeks.
So we're not talking 2014 here. We're talking about a beautiful new ER, if you don't mind my using that,
Not
and
at all.
ICU facility for past residents in just a few weeks.
Yes, we hope so. And just so it's not misleading, mainly we currently have an ER and an ICU. This new building will replace our existing ER and ICU with new space and more beds in both units so that we can take care of more patients in modern facilities.
Who do you service at San Gorgonio?
Mostly the people that live in the San Gorgonio Pass area, so that would be the residents of Banning and Beaumont primarily, but also residents Cherry Valley and Cabazon, Calamasa, as well as people that are passing through the area on I-10, or they're visiting the area, or they happen to come from outside of the area just because they've been referred to our hospital by their doctor.
How many people generally does that represent?
Well, in our pass area, there are approximately 89,000 residents in the area. So that's who we're predominantly serving and the reason for our existence. But the greater areas, many more, hundreds of thousands of people in the area.
You had mentioned the growth that we went through, and you're expanding to meet that growth. And I talked about that in the open. In fact, the Inland Empire was growing by leaps and bounds, to use a cliche. And then it all seemed to come to a grinding halt when the housing downturn occurred. Is it recovering?
It's slowly recovering. We're beginning to see an uptick in housing development and the number of homes sold. I don't know how fast that's going to resume in terms of the kind of speed of development that was happening in, say, 2006, 2007. But it's expected to pick up again and like a wave pass through the pass area with a number of new housing developments. In fact, as I mentioned, we're at 89,000 in population now. Once the area is completely built out, it's projected to hold a population of somewhere around 220,000 people. So our building plans take into account this population growth.
Okay, Mark, you just said a number that doesn't represent, say, a 10 or 20% growth. You're talking about almost a tripling of the resident population that you have to be able to handle. And I imagine all the facilities in the Inland Empire likewise have to be prepared for renewed growth, the people that are going to move in, and the family expansion that happens organically right here in the Inland Empire.
Correct. And the pass area is on the periphery of all the growth area, and we're not the only area that's going to grow quickly, but we're certainly in a position to grow fast like we did previously and in the future. My understanding is as little as 10 years ago, we were total population in the pass area of maybe 40,000 people. So we've already more than doubled, and then we're going to about triple from that point forward. How long that's going to take, anybody's guess. Depends on the economy and demand for housing. We expect it to come fairly quickly, though.
You mentioned you expect it to come fairly quickly. I imagine that's because the building permits, the development plans, are already being submitted to the cities. I mean, there's already the preliminary stages of the growth happening under kind of out of sight.
Right. The cities of Calamasa and Beaumont and Banning already have several housing development projects approved or in the process of being approved or being discussed and hopefully will be coming up for approval soon. This represents, I don't know, I can't even remember how many thousands of new homes, and probably over 10,000 new homes in the pass area. So some of the construction has already started, some's already been approved, and they're awaiting construction, and some will be approved probably in the next 3 to 5 years that will essentially build out the entire pass area if there's demand for those homes.
So you're going to have to become a much larger facility. You mentioned
Yes.
your stages and this new building that's being opened, including the ER and ICU,
Right.
And infrastructure. Tell me about the infrastructure needed to go into developing an expanded hospital.
Yeah, our first phase required us to develop our above ground and below ground infrastructure. And what I mean by that is we needed to have a central utility plant that could accommodate the boilers and chillers and backup generators and medical gases and things that would supply not only the existing buildings, but any of the new future buildings that we're going to construct. And then to carry those utilities from the central utility building to all of the existing and future buildings, we needed underground tunneling to carry the heating and the air conditioning and the electricity and the water and sewer and what have you, medical gases, to all of the current and future buildings. And all of that infrastructure had to be put into place first before we could put any new patient care buildings in. So our phase one encompassed all of the infrastructure investment and improvements, and included the two-story emergency department, ER, and ICU services as well.
So you're well prepared not only for the opening of this building, but the future phases that are going to build even on what you have now.
Correct. That's correct, yep.
So let's talk a little bit about what services you offer. For a lot of people, they think an emergency room, you watch the television show ER, everything comes in your door. But in fact, there's generally a set of services that you offer and some others that you don't. Kind of go down the list for me of what people would use your facility for.
Yeah, we do have a very active emergency department, but most of those visits are what I would classify as doctor office visits or urgent care visits. So it's the fevers and the cuts and the bruises and minor ailments. But we also have the heart, ailments or respiratory difficulties or pain in the stomach that needs to be addressed. And so we do take a broad range of, or provide a broad range of services for those that come in the emergency department. What it's safe to say that we don't provide is major trauma. So if there's a vehicle accident or multiple injury accident, those types of patients would be sent to a trauma center like Riverside County Medical Center. So we don't do the major trauma, but we take care of most everything else. In the hospital itself, we deliver babies, we have general surgery services, orthopedic surgery, gastroenterology, as well as just general respiratory and ICU services as well.
So heart attacks?
We do address those, yes. If the patient requires any invasive procedures, those patients are transferred elsewhere, but we can treat initial heart attack patients, yep.
Hernias?
Hernia repairs, yep. Delivering babies.
Appendectomy?
Appendectomies, correct, yep.
And of course, joint and like
joint
you said,
replacements and joint repairs and right, yep. The bread and butter of hospital care. So. And
differentiate yourself. You've already done it from a trauma center. And since we're talking about the IE in general, tell me, where are the trauma centers locally?
Riverside County is one, I believe, and Arrowhead Regional in San Bernardino, Loma Linda University Medical Center. Those are the ones I'm aware of.
Now differentiate it from, say, your urgent care facility. What are the kind of services that you would offer that somebody would choose not to, say, go to their local PPO or HMO urgent care center?
I think if you're having heart pain or respiratory distress, you would probably want to go to an emergency department, ours or someone's, rather than urgent care. I'm not a doctor, so I can't tell you where exactly you're supposed to go, but I think anything that would be life-threatening from the patient's viewpoint probably should be dealt with an emergency department. The other thing about urgent care centers, and there's nothing wrong with those, I think it's a very valuable service to our community, and we have one in our community as well. But they do close down in the evening. They don't stay open 24 hours a day. Our emergency department is open 24 hours every day of the year, regardless of holidays or what's happening in the environment, or if there's a major earthquake. We are open, we have to be open, and we treat all patients that come in.
And all the supporting departments as well, I imagine, radiology and lab and...
Correct. If you have an emergency department and you're licensed as a hospital, then you have to have surgical services ready to go. So either on site or on backup on call, as well as lab, respiratory therapy, radiology, imaging work. And all those departments are staffed 24 hours a day, 7 days a week.
Mark, you mentioned earthquake event. The bombing in Boston, kind of obviously a tragic situation. It really stressed the local hospitals. They were expecting runner injuries, fatigue, heat stroke, and got 170 patients with
Trauma.
yeah, trauma. If a major event happens in the pass region, is your ER capable of handling that kind of an influx?
We are capable of handling a surge of patients from a major disaster. We practice that through regular routines and events that we use to mimic what might be a natural disaster or a man-made disaster that would happen in our area, so that we can test our resources and our staff to see whether we can properly handle a large influx of patients. So we have surge tent, for example, that we can erect and put up to temporarily take care of patients. Now, the new emergency department building is going to greatly enhance our ability to take care of a large influx of patients, because we're going to have more beds and more space and more staff to take care of those. But we do train our staff to be able to take care of a natural or a disaster that might happen in a large influx of patients.
One of the disasters so many people think about when they think of Southern California is an earthquake disaster, which, when you ponder it for a moment, you realize that if everything is shaken and buildings are collapsing, the hospital's collapsing too. How are you going to be able to service that kind of an emergency?
Yeah, great question. Really, the motivation behind the construction of our current buildings on our campus and the infrastructure was largely motivated by the seismic laws in the state of California. All the hospitals in the state are required to meet certain seismic compliance regulations in terms of the engineering construction of their buildings, so that the buildings not only will withstand a major earthquake, but also will be able to continue functioning. And by functioning, I mean being able to function as if everything else in the community failed. So if we were cut off from the city water or the city's electricity because of a major earthquake, we have to have the ability to generate our own electricity and have our own supply of clean water to be able to continue operations as if the earthquake had never happened, because we will be the refuge that people will be seeking after a major event. And so that's really the primary motivation behind the construction. In our particular case, we need it for growth as well. So,
fortuitous.
Yes.
So I want to remind our viewers, of course, we are a live program. They can call in and ask a question of Mark, email or tweet, and in fact, a couple have emails. So Mark, I'm going to go to our first one. I'm going to take Owen of San Bernardino, who emailed, does Bayer really help with heart attacks? Does Bayer aspirin help with heart attacks?
My understanding is it may, but I'm not a doctor, so I don't know that I can give that kind of advice or an answer. So I'm going to.
You're going to qualify it there.
Yes.
Yes, I understand. Another one, Lynn of Beaumont. Thank you for emailing. The opening mentioned facilities for the family of patients. Do they have to pay to stay overnight? If so, is it as expensive as being an actual patient, or is it like hotel charges?
I'm sorry, the opening of...
Yeah, the opening clip that we saw,
yes,
it talked about how the recovery rooms in the ICU were expanded such that the family can stay 24 hours.
Oh, no, we wouldn't charge for the family members to stay with the patient. In fact, we encourage the family members to stay overnight with the patients once this new ICU opens up, because it will help in the healing process for the patient. So, no, there's no extra charge for that.
We all remember the shows where the nurse, in the movies, the nurse tries to kick the person out, and they resolutely say, you couldn't possibly kick me out, I'm going to stay with my loved one.
Yeah, a lot of that's changed. I think we recognize that a large part of the healing process is having the family members available. The other side of that too is the facilities were never large enough to accommodate several family members, even one, in the ICU room with the patient, because the patient's surrounded by staff that are attending to them as well as equipment that's monitoring. We, in the past, apparently didn't allow for enough room to have family members stay with the patient. We've designed these rooms so that they are large enough to accommodate patient, equipment, staff, and family members.
Let me ask about the demographics of our region. Historically, we've had a lot of farming and ranch. Lately, we've had before the housing downturn, we had a lot of influx of people moving out from the LA basin to the Inland Empire. Mm-hmm. Larger houses for the same money, a little better spaciousness, you know. And then we also have, for instance, Native Americans in our region and others that we service. Large families and, of course, seniors. Hemet, our area, has a lot of seniors. What do you see as kind of the specialty? I know you have broad services, but what are kind of the specialties that you offer for those different demographics?
Yeah, and we have, our community is comprised of predominantly 3 or 4 different groups. There's the group of folks that have been in the Banning Beaumont Pass area for their entire life, and they've been there for a very long time, and they remember what our hospital used to be like and what the community used to be like, and it's changed dramatically, and it continues to change. Then we have those that have moved into our community because of this 55 plus housing communities, the senior housing. And so we have a number of people that are larger users of healthcare services, particularly of the hospital, particularly of the emergency department, that are 55 or older. And then we have the third group, which are these larger housing developments that are attracting working families with children who are moving in from other areas of the Inland Empire because it's an attractive price for what you can get for a house, but it's still within commuting distance of San Bernardino, Riverside, Redlands. And so we really have several unique groups that have moved into our area. We do our best to accommodate all of them. Most of the services we were providing, though, are for the 55 plus community and obstetrics for the families, although we have quite a few that come through our emergency department with various cuts and sprains and things like that. So.
Mark, we're talking about the expansion of your hospital, and I imagine this is true of the other hospitals in the region too. Is it true that you just build a new building and suddenly you have greater capacity to service the community?
I wish it were that easy. No, the facilities have to be there. They have to be large enough to accommodate the volume, and they have to be configured such that we can provide care efficiently and effectively. But we don't see patients, except through the emergency department, we don't see patients unless we have doctors. And doctors are critical to the success of any hospital. They're certainly critical to the success of our hospital. We've been blessed to have a very qualified medical staff already, but we need more because of the growing population. And we need them in various specialties that can accommodate orthopedics, for example, or GI, or general surgery, or even just family medicine. So doctors are critical to any hospital's success.
And you're beating them off with a stick, right? You're telling them, oh, we just have all that we need.
Yeah, no. We had a shortage before the population growth in our area, and as we have more people move into the area, we're going to continue to need even more physicians. The IE has a fairly significant shortage of physicians in almost every specialty, and we're no different in the pass.
You know, one of the best ways to increase the number of physicians in a community is by having a local medical school. UC Riverside is rising to meet that challenge in a remarkable way. Let's hear from Dean Olds as he discusses his innovative plan to create the first new medical school in California in the last 40 years.
Well, you know, there really isn't any way to do this by just building a med school. So let's go over what our unique missions are. Probably the mission that is most publicized is to specifically address the healthcare manpower shortage in inland Southern California. So how do you get doctors to practice in inland Southern California? The second issue is it's not just more doctors. You need more doctors that are going into specific specialties. So how do you create an environment where a higher percentage of your graduates go into the fields of medicine that are actually needed by society rather than the ones that pay the most or the ones that the students think have the best lifestyle, etc. Then we have the interesting challenge of how do we create healthcare professionals, in our case medical students, that are more reflective of the populations they serve. And there are some advantages to doing that, which I'll point out, but it's also the right thing to do. And then finally, the really unique mission of the med school is to actually improve the health of the community we serve. Now, you would think that that would be the mission of every med school in the United States, certainly every public medical school, but it's quite a unique mission in the United States because we tend to not think of populations. We tend to think of the patients that come to our hospital, the patients that come to our clinic. No one tends to, in the United States, to think of the health of our entire population, and we need to move in that direction as we move toward more universal coverage. So, How do we accomplish the first mission, which is we have an overall shortage of doctors in inland Southern California? It's about 3,000 physicians today. It'll be about 5,000 physicians in 10 years. That's a huge physician shortage. We are short of virtually every type of doctor except plastic surgeons. So how do we just get more doctors to practice in inland Southern California? There are only two determinants of why doctors practice in any location: where they come from, equally divided between where they're born, where they went to high school, and where they went to college, and where they finish their training, that is, where they finish their residency training after medical school. So the med school is somewhat irrelevant, if you will. So if I just build a med school, I would fail in that mission. So to be successful in that mission, we, in contrast to most medical schools, have to be very active in pipeline programs to bring more qualified students to be selected in medical school. And this is quite a challenge because inland Southern California has the lowest college going rate, it has the lowest standardized test scores, it has the highest high school dropout rate, and we have to address that issue in part in order for me to have enough qualified candidates to select. So we are actively involved in K through 12. We have success programs not only in our own university, but we're building success programs in other universities with high numbers of inland Southern California students in them. So that's the front end of the med school. Then on the back end, I have to build new graduate medical education programs in the disciplines in shortest supply. Now, I should point out that we are the only new medical school in the United States that is also building graduate medical education programs. Every one of the others, 15 out of 16, are just building a med school on the front end of existing graduate medical education programs. There's probably a greater shortage of graduate medical education programs in the United States than medical schools, so that's very important. So what are those short supply specialties? The three primary care specialties of family medicine, primary care internal medicine, primary care pediatrics, general surgery, OB, and psychiatry. Just a brief comment on the last three. General surgery, because we're largely a rural county, and every one of those small rural hospitals have to have a team of general surgeons in order to stay open, and there's a shortage of general surgeons, and they're critical to maintaining those small hospitals. OBGYN, because we have the highest fertility rate of any area of California, so we have an awful lot of children being born. We need specialists in that area. And psychiatrists, because we tend to not comment on the woeful manpower shortage in mental health services, but it's just as big as primary care, and so we need more psychiatrists as well. Now, how do you do that? Well, the first thing to do is to look for the characteristics in your medical students that will track with careers in those areas. Now, we are fortunate, I guess I would say fortunate, in California in that we have so few medical schools, so few medical school slots, that we have about 10 qualified candidates in California for every med school slot in the state. That compares with a national average of about 2.5 to 3 to 1. So we're woefully under med schooled. But the good news about that is that there's a ton of highly qualified candidates to pick from. I would just argue we're picking on the wrong criteria. Now, granted, you have to have a certain grade point and certain standardized test scores in order to make sure that you'll succeed in med school, but that's still a huge pool. So within that pool, I don't pick the students based on who has the absolute highest grade point or the absolute highest standardized test score. Instead, I look for qualities that help predict going into many of these helping fields. So for instance, one of the strongest predictors of going into primary care is previous service in the Peace Corps. Think about that. A student that takes 2 years out of their life to do something for other people, potentially in a third world country, probably tells you something about that student that probably tracks with their likelihood of going into underserved areas in our own neighborhood and serving that population. So we put a lot of emphasis on service-based learning, on previous experiences that demonstrate to us an altruism and commitment on the part of those students. In addition, in our interviews are different. We don't just have you show up and take 2 random interviews with 2 faculty members. We use what's called the multi-mini interview technique. And so we have questions generated specifically from our unique missions. And we ask every student, basically, they walk up to a room, they're given a question, they get 2 minutes to think about it, and they walk in the room and they get 8 minutes to answer that question. And that faculty member that hears their answer, hears the answer from virtually all the students that are applying. But what it does is it tells us more things about each of those candidates than a standard interview would. And it particularly tells us about things about that candidate related to our missions. We also, interestingly, have a different attitude about our partners. You know, we're a community-based medical school, which means that we do not build a university hospital. We partner with all the existing healthcare infrastructure of our own community, clinics, hospitals, doctors, etc. But other medical schools haven't considered their value in selecting students from our own geographic region. So, for instance, a local hospital might have 100 students that volunteer in that, trying to improve their odds of getting to med school. Has anybody ever thought of asking the hospital, and particularly the nurses in those hospitals, out of that 100 students, who are the 2 or 3 that would really make great doctors? They know, you see, because they've worked with them. That knowledge would be very helpful to us in selecting the students that have, if you will, the right stuff. So we put a lot of emphasis on picking students that we think have the right stuff, not only to go into fields that we want them to go into, but have the right personal qualities that you and I would both want in our doctor.
We're back with Mark Turner, the CEO of San Gorgonio Memorial Hospital in Banning. Mark, let me ask you, is Dean Olds on the right track with this community-based medical school?
I think so. The points he made about attracting students that would be trained and then would stay local, I think are right on target. Finding those students that already are from this area will be, in large part, a determinant for having them successfully stay in this area once they are done with their residency and begin practice. The other thing is, by having the residency program after medical school associated with the local area hospitals and clinics, I think is also a good way to train those doctors, get them familiar with the practice in the area, and then to remain, because they're going to already be familiar with what's around here. So yeah, I think he's right on target.
Great. We'll delve a little bit more into it. First, I want to take an email. Kobe of Rancho Cucamonga. What's the difference between a physician and an MD?
There isn't any difference. An MD is a type of physician, a medical doctor, but a physician can also be a doctor of osteopathy, a DO, so there's no difference.
Although I don't know what that last term is.
Most doctors are MDs, some doctors are DOs.
Okay. You talked about doctors and doing the residency in the local community-based facilities. How is that different than UCR building a medical school?
You know, I'm not an expert on medical schools and how those work, but most of the ones that I've been familiar with are considered academic medical centers, and so the doctors would train within a one hospital or a hospital center, particularly those that would be in specialties. And so most of their exposure and experience would be in one hospital, in one location. I believe the type of system that Dean Olds is trying to put together will rely on using multiple hospitals and multiple locations of practice to be able to train their students.
Is San Gorgonio a candidate?
I'm waiting for Dean Olds' call, but we would like to be. I think we would be an attractive target for certainly family medicine, internal medicine, and perhaps even general surgery. Those are things that we do routinely. And so we would like to be part of that as well.
Mark, you mentioned this notion that if they're from here already, they're more likely to stay here, especially if this is also the region they do their residency in. Mm-hmm. What are some of the factors that compel doctors not to practice in the Inland Empire?
Well, again, part of it I think is just familiarity. If they're not from here and they didn't train here, because there isn't anywhere to train, then they're not going to be familiar with this location. And most doctors are going to go to locations that they're familiar with, either because they have family there or they trained there. And that's familiar, it's comfortable, and they already kind of know the surroundings. If we don't have a residency program in our area and they're not from here, it's extremely difficult to convince a doctor to come to this location just because they have no knowledge of our environment and are reluctant to come here without knowing someone or having family here or having some familiarity with it. Many of the doctors that practice in our hospital and in our location come out of the Loma Linda program, and that's no surprise.
Dean Olds talked a little bit about this notion that I'll characterize as kind of philanthropy or altruism, this idea that if you've served in the Peace Corps or you've done other kinds of service, community-based service, it's an indicator that you may be willing, and I think unstated in there, and I don't want to put words in his mouth, is this idea that you may be willing to drive the S550 and not necessarily need the AMG version of your Mercedes. Is that what you're looking for, doctors that are more interested in the helping aspect as opposed to, as he said, Southern California's propensity for plastic surgeons?
Yeah. Well, and I don't, in this particular area, I don't know that we're attracting the physicians who are trying to maximize their income as much as we're trying, as the doctors who might be coming to this area because they see an opportunity to help and earn an income. And so your analogy might be accurate, but what drives them exactly, I'm not sure. I'd rely on what Dean Old says in terms of finding the right candidates to be placed in this particular area. But I like his idea of trying to attract local students, people who are already familiar with the area, to get into the program, train locally, and then stay here. Those are the folks that are going to stay here their lifetimes.
Let me take another spin on that, viewing from a different facet, a different angle, not so pessimistic. Well-meaning doctors that serve in the Inland Empire, do they burn out?
Yes, I think they can. We have and this is a problem I think throughout California, we have a high percentage of the population that's uninsured, and those folks need care too. But in order for doctors to maintain their incomes, they need to see more patients, because if they're seeing the uninsured patients, then they also need to see so many insured patients to maintain what they believe is a valid income. That can often lead to overload. It can also lead to overload if we can't find enough physicians within a particular specialty to provide relief to those that are already here. I think it's especially acute right now with gastroenterologists, a GI doctor.
Which is stomach, generally.
Yes, yeah. And they are the ones that are the most, we're finding the most difficult to attract to this area. I'm not exactly sure why, but I think burnout has something to do with it.
So Inland Empire doctors, in the absence of the UCR Medical School, for instance, can find themselves with a lot of patients, especially those in specialties, and low remuneration rate because of the high propensity for uninsured. Let me ask, as an administrator, are you familiar with any aspects of Obamacare that's going to be changing that or has been taking steps to change that?
Well, there's a lot of details that need to be worked out at both at the federal and state level to implement Obamacare and get that rolled out. It's going to take several years for that to happen. And so right now, it's unclear exactly how things are going to shake out. Is it a good thing that more people are going to be insured and showing up at the doctor's office or at the hospital with an insurance plan that will provide some remuneration? Yeah, absolutely. That's a great thing. Will that remuneration be the same as what we're currently seeing today from commercial plans? Don't know yet. We haven't seen the rates. So it's unclear exactly where the money's going to come from to cover all of these folks that are uninsured right now. And then in turn, what are the providers going to get paid for these newly insured patients? There's a feeling out there within the industry that there'll be more people covered by insurance, but the providers are going to get paid less on average from all the insurance plans to help pay for it. So I don't know that it's going to change the game all that much more, except that more people will be insured and covered and feel welcome to see a doctor, to have issues dealt with before they become acute.
Yeah, we talked a little bit about the difference between San Gorgonio and urgent care, San Gorgonio and acute care or trauma centers. What's the difference between your hospital and, say, a county hospital?
Well, a county hospital really is there to as a safety net. They're there to support healthcare services for the indigent, the uninsured, the people that don't have insurance coverage. And they get special funding for that. Other hospitals in the area do their best to take care of those patients as well, particularly those that come through their emergency department. When we have patients that come to our hospital who do not have insurance, We do try to contact the county to see if we can have those patients transferred there, but oftentimes they're overwhelmed with patient loads already themselves. And so it's really become a capacity issue in Riverside and San Bernardino counties, where the county hospitals in each respective county just simply don't have the resources and the capacity to take care of all the patients that are not insured and might show up at any of the hospitals in the county. So that burden falls back on community hospitals like ours.
If they can't be transferred, you step them out onto the sidewalk and say good luck?
No, we don't. No, no, we will take care of the patients within our institution. We'll continue to find ways to transfer them to county if that's appropriate and they have availability. If they need a higher level of care, of course, then we'll search multiple hospitals to see if we can transfer the patient so they get the appropriate care that we might not otherwise be able to provide in our hospital. But no, people don't get thrown out on the streets.
So you do provide some level of care. I think in California you're required, I think you told me that you're required to screen. What is it that you do?
Yeah, any patient that shows up at our emergency department, regardless of their insurance plan or ability to pay, needs to be medically screened and stabilized before we have any conversation about how they're going to pay for the services that our hospital provides. In our particular case, since most of the patients that come into our emergency department are there for more office-type visits or urgent care, by the time you do the medical screening and stabilization, you've done just about everything except write the prescription for the medicine that they need. So we routinely just follow through and take care of everything for the patient, and that's part of our mission.
For which the state then compensates you, saying, well, they didn't wind up at a county hospital, but you took care of an uninsured indigent patient, for instance, so we'll compensate you.
The state would compensate us for that type of care if the patient qualified for Medi-Cal, for example. But if they don't qualify or they choose not to pursue that coverage, we have to absorb that cost. We don't get paid.
That's got to be very difficult for a hospital to maintain its viability in the face of a large uninsured population that can show up to your emergency room if they, have the need.
Yeah, it's a challenge. It's a challenge not only our hospital is faced with, every hospital in the Inland Empire is faced with the same issue. I believe, I know our mission, and I believe pretty much every other hospital in the area's mission is to take care of the sick and injured, particularly if they come up in our emergency department, and we're going to do our best to take care of them. But it's a challenge, and it's a challenge that's grown in recent years because of the economic situation within the country, people losing jobs or coverage. We have seen an uptick in the number of people who do not have the ability to pay for their care, and we're no different from any other hospital in the area.
You mentioned to me previously this notion that if somebody does receive care for which they cannot pay, there is a system by which the hospital can receive some kind of consideration by grouping it into charity care, but it requires some work, some paperwork on the part of the person that was treated by the facility, and you find it challenging to get the people that were cared for to actually follow through with that paperwork.
Yeah, for those that receive services at our hospital, and these are typically patients that come through our emergency department and need urgent or emergent care, the service is provided before we have any conversation about how it's going to be paid for. And if a patient doesn't have insurance coverage and they don't have the financial means to compensate the hospital for those services, then they can qualify for what we call charity care. There are paperwork forms that need to be filled out so that we can verify that they don't have the income or the assets or the insurance coverage to pay. But a lot of times people don't want to go through the process because it is paperwork intensive, requires a lot of time on their part, and they've already received the service. So there's not anything they're going to get out of it other than we won't pursue them for payment of a service that they can't pay for anyway. But we do our best to work with them to make that process as painless and easy as possible. And the benefit to the hospital is that we can then show the state and federal government that we are in fact providing free care for those that can't afford to receive that care. And that's in lieu of paying income taxes because we're a tax-exempt entity. So we would like to classify the care that we provide for free as much as possible as charity. Requires the assistance of the patient to help us do that.
I'm going to go to the phone, and we have a call. Maya from Lancaster, you're on the air. What's your question?
Yes, Mr. Turner, I am a physician. I am calling you from Lancaster. I have a daughter who's born here, and she is a UCLA graduate, done med school in India, and she has done all her USMLEs, is California certified for residency, but is having a hardest time getting a residency. She wants to do primary care.
So you're asking, and I'm going to extrapolate here.
How does she apply to your institution?
Good question. Thank you, Maya. So you have somebody, this person has a daughter, undergrad at UCLA, it sounds like, went to medical school in India, wants to be a resident, sees from our show that the Inland Empire is missing family care physicians. Can they do a residency at yours or another regional hospital?
Not directly at our hospital. She'd have to go through a certified residency program associated with medical school program. We don't have that capability at our facility, so unfortunately we can't assist in this particular case. And I am not that familiar with how foreign medical graduates apply and get accepted to residency programs, although I know that that occurs widespread throughout the country. Exactly how it works, I'm not sure.
Okay, sorry we didn't have a better answer for you, caller, but I understand because you're not a doctor.
Correct.
But you are waiting for that call from Dean Olds to begin that residency partnership with UCR.
That's right.
Okay, so tell me about the next phase at San Gorgonio Memorial Hospital.
Okay, well, the next phase in our construction is to complete a 6-story building that will replace the remainder of our inpatient rooms that are not part of the ICU or the ER. And that will also give us additional capacity and licensed beds. So that new facility, once constructed and opened, which if we stay on track should happen over the next 5 years or so, would give us, would increase our licensed bed capacity from our present 77 beds today all the way up to 151 beds. And these would all be private rooms, which is nice for the patient's family, again, to have the patient family members there to assist in the healing process. But it also gives the hospital more flexibility too, because when we get patients that come through the emergency department that need to be admitted, as long as we have an available room, the patient goes right in, speeds the whole process. Better than what we have today where we have dual occupancy rooms and we have to place patients appropriately. In other words, if we have a bed available in a dual occupancy room and we have a male patient that needs to be admitted and a female patient is in the room, we don't mix those two. We don't mix infectious with non-infectious. We don't mix children with adults. So dual occupancy rooms present a challenge for us operationally, for the families, for the patient, for everyone. It once upon a time was acceptable. Today it's not. The new building would eliminate that problem. We would have all private rooms. Concurrently with the process of construction, what we're doing too is we're working very closely with the Beaver Medical Group, who has a large presence in the Pass area, to recruit more doctors into the community. Because again, back to your original point, we can build the buildings, but we can't have the patients, take care of the patients unless we have the appropriate number and type of doctors available to take care of the patients.
Mark, you're saying now you're partnering or working with Beaver Medical. I would have seen them as kind of a competitor. How does the partnership work?
In fact, it's not really competition at all, because Beaver Medical Group provides physicians and medical care to patients. And they need facilities to see their patients in, not just their own clinics, but also in hospital settings. And so the doctors that are placed in the San Gorgonio Pass area, seeing patients in their office, if their patients need to be admitted to the hospital for surgery or medical reasons, then they have, and they're on our medical staff, they can see their patients in our hospital. And so we're dependent on them. They're somewhat dependent on us for having the hospital services available for their patients. So the synergy works quite well. And we've chosen to work collaboratively with one another rather than independently.
So there's a bit of a symbiotic relationship there.
There is.
Is it kind of a misnomer to think that people, the physicians that are in your hospital or working with people in your hospital are employed by your hospital?
That's a common misperception that doctors work for the hospital or somehow are employed by the hospital. None of the doctors work for or are employed by the hospital or any hospital in the state except for maybe Kaiser. And they are independent contractors. They have their own practices. They may be individual practices, they might be small group practices, or in the case of Beaver Medical Group, large multi-specialty group practice. But in any case, they're independent of every hospital in the state. And they happen to have medical staff privileges at our hospital, and that's to be able to use our facility and our staff and equipment to treat their patients. But that doesn't mean that we employ them or we have any type of, or that they work for the hospital.
So in this scenario, you as a patient would see your physician of choice, typically at their clinic, but when it came day for surgery, maybe it's an in-hospital inpatient surgery or perhaps even a one-day outpatient surgery, you would proceed to the hospital on a scheduled appointment basis, and your hospital would then make its surgery center available for the physician, for that surgeon's use, and you, the patient, would be treated at San Gorgonio.
Correct. And so let's just take a hip replacement surgery, for example. The patient would start out by seeing the orthopedic surgeon in his or her office practice first. And then a surgery, if it was deemed necessary, a surgery would be scheduled at our hospital. And then the doctor and the patient would both arrive so that they could get the patient prepped by our staff, and they can go into surgery, do the procedure, and have the patient recover after surgery in our hospital, whether it's that day or they stay for several days, as the case may be. And so the doctor is really just using the facility to care for his patient and using our staff and equipment. And in that particular case, it would be on a scheduled basis.
There's a trend in healthcare to have these independent surgery centers that are small, run by several partner doctors. How would you contrast your surgery center versus those small centers?
It's somewhat different in the sense that in a hospital, the surgical services are going to be staffed and equipped such that we can take care of both scheduled elective cases, like an outpatient surgery center could do, but we also have to be equipped and capable and ready to be able to take care of emergency services, surgery services for those patients that come through our emergency department. In a hospital, the emergencies are always going to take precedence, even if we have cases scheduled. So if we have, say, an emergency C-section or emergency surgery for an appendectomy, those patients will bump any other scheduled patients. And so that would be the primary difference between a hospital surgery services and an ambulatory surgery service.
The important thing to remember in this case, though, is that emergency room. You have to have surgery centers attached to the emergency room.
We do.
And you cannot displace your kind of a hospital with these small little outpatient surgery centers because they don't provide those emergency services. They, I imagine, aren't open 24 hours.
Correct. So much like the urgent care centers that are around, an ambulatory surgery or an outpatient surgery center also would turn off the lights and send the staff home sometime in early evening and not be available after hours. In a hospital, we have to be available 24 hours a day, 7 days a week, not just the emergency room, but also surgical services and imaging and lab, so that we can take care of emergencies. If, I suppose if there was too much competition from outpatient surgery centers and freestanding urgent care centers and other services that would compete with the hospital, it would jeopardize the ability of our hospital to remain open, and then you would lose those emergency services.
So as a community, it really benefits us as a whole to use those doctors that are contracted and medical staff of your hospital so that we maintain the viability of your expanding hospital and maintain our access to emergency services.
It is important. Obviously, it's still incumbent upon us as operators of the hospital to provide the best quality care possible. We're not asking anyone to use our hospital otherwise. So it's a healthy competition with these outpatient centers, and they do serve a purpose. We just want to make sure that we can maintain the viability of our community hospital because we provide a much greater service to the community.
Thank you, Mark.
You're welcome.
I'd like to thank my guest, Mark Turner of San Gorgonio Memorial Hospital. Join us next week as we examine the health care offered to our local military veterans. I'm Roger Bowman. Thank you for watching Plugged Inland. Great job.